while they're pulling up the slides, maybe I'll ask, who here does prone PCNL? Who here does supine PCNL? Okay, so it's a slight uphill battle to win, but we're going for it. So when it comes to supine PCNL, the talk I'm going to give you is really going to be, what are we talking about? What is supine? Why should we do supine? And then lastly, how do we do supine? And I'll give you some take-home points. So positioning is a complex issue. When it comes to prone, we're kind of used to prone, but there's some variants. You know, you can bend the table a little bit, you can do a split leg prone, get a fancy table. When it comes to supine, though, it's a lot less clear. So there's the Valdivia, there's the modified Valdivia, there's Bart's, there's flank-free Bart's. We don't even know what we're talking about. So supine PCNL in general, we're not used to looking at it. We're used to looking at a picture like this, where we see prone position. You've got, again, the 12th, 11th, and 10th ribs. That's number one. The iliac crest, number two, and the paraspinous muscles. That's what we're used to. I'll show you what I do in terms of the supine position. It's not a true supine position, but rather I use the Galdico modified Valdivia position. So patients in stirrups, they're not totally flat. I have them propped up about 15 to 20 degrees. So usually I'll use a lithotomy with my yellow fins. I externally rotate the hips. I have a bump underneath the hips and the shoulder, and the ipsilateral arm is fastened across the chest, and I'm bringing the patient to the side of the bed. So that's what I mean when I say supine. And this is what I would advocate because it's a very easy position to get to and to use. But the same landmarks are present whether you're prone or supine. So we're still kind of explaining, well, what are we talking about? So in the supine position, you have your 10th, 11th, and 12th ribs. You've got your paraspinous muscle back here. Here's the mid-axillary line, and then the iliac crest. The same landmarks are present whether or not you do supine or prone. So from this positioning, kind of the anatomy is the same. And now I'm going to move on to the concept of, well, why should you do supine? I'm going to make two arguments. The first argument is, I just gave you a talk before about how terrifically we can move towards X-ray free PCNL, and then I ended by saying, but it'll take you a little while to actually master ultrasound guided dilation. Supine positioning is actually the easiest access to totally X-ray free PCNL. The reason for that is, and this paper just came out this year. It's still in press, so it's not fully finalized. But when people actually randomized patients to supine and prone, outcomes were the same. So 392 patients, half of them got supine, half of them got prone, and they were fully ultrasound guided PCNLs, and they had equivalent outcomes. So we'd all love to get there. And the reason why I think it's easier to get there doing supine is a paper from this year also out of the Japanese group from Nagoya. These are terrific guys here. So this is what a supine PCNL looks like in their hands, and it's the same as what I showed you before. Here's the needle coming in, here's the kidney, here's a calyx here, here's a calyx here. They've stuck it in. Now, if you haven't done endoscopic guided PCNL, the beauty of that is that once you put the needle in, you can see the needle coming in when you have a ureteroscope in. And then, this is where it gets nice and magical. This is not my video. This is a video I took from the Pacific Northwest Urology group. But once my needle's in place, the wire comes in under direct vision through the needle, and then your balloon comes into place. You're watching this all under an endoscope, and the balloon's now being blown up. It's moving the tissue out of the way. There is an axis sheath in, so in favor of Mitch Humphreys. That's why it's a little decompressed. And in a moment, you're going to see the sheath thing getting pushed up. So here's the balloon. It's dilated the system. You can see the tip exactly where it wants to be. There's no question about your location because you can see it in front of your eyes. And the sheath is coming through in a moment, and you can see this clear sheath now coming through. All of this is done with no X-ray. So you don't need to worry about all the complex things I showed you about using ultrasound. There's no fluoroscopy here in the room. You can do all of this under endoscopic guidance. So now, if you can accomplish ultrasound like I showed you in the first talk, and get to a supine position where you can put a scope up and do this, you have X-ray free, easily in your hands. And the second set of arguments I'll put up are kind of a comparison between the pre-op advantages and the intraoperative advantages. And in full disclosure, I do both. So I trained in prone. I only did prone because I was told that's the only way to do PCNL. And then we started doing supine, and it turns out there's some advantages. So one, I think hopefully I've convinced you now, if you do a combined endoscopic approach, you can do it prone. So people use a split leg table, but you got to get special fasteners. You can do it prone without split leg, but you have to get over that learning curve. Supine, it's kind of what you're used to. So if they're in lithotomy, everybody here does lithotomy, cystoscopy all the time. Lithotomy, ureteroscopy all the time. It's the same. Patient positioning, after for years going around and lecturing and saying how prone positioning is super easy, you just flip them over, it takes you a minute, it's no problem. Now that we're doing supine, every time we say, the nurses will come up and say, do you want to do a supine or prone? And we say prone, you can hear a little groan. I go, oh. It is much easier to do supine because you don't need to flip the patient. You just move them over like you're used to. That means you have the number of staff that are, you don't need as many staff because you don't need to flip them. And the anesthesiologist is much happier. So whether or not we care about anesthesiology happiness, that could be a different debate, but they're happier because it's easier to do. When I do a supine PCNL now, it's just an LMA. So patients don't have any sore throat. It's a much easier anesthetic. Intraoperatively, I think there's a couple of advantages here. A couple I'm going to give to prone. The first is that if you're going to do an upper pole access, prone gets you better upper pole access. There's no question. You have more medial control. You can get to the upper pole easier. And if you're going to do a contralateral PCNL, so it's simultaneous PCNL both sides, it's just easier to get from one side to the other without having to reposition the patient. So I'm going to give those to a prone position. But the nice thing about doing a supine PCNL is that if you want to minimize your access tracts, you can do that. So on a patient that has an upper pole and a mid-kidney and a lower pole stone, sometimes I'll get to the upper pole puncture and I can't get to both other calyces, but if I go up with a ureteroscope, I can pass that stone up or break it up a little bit and then flush it up to the upper pole axis where I can suck it out with my other scope. So that's a big advantage. Instead of having had done 2 or maybe 3 accesses one case, now I can do 1 access and use the ureteroscope to clean the rest up. Contralateral ureteroscopy, so if I have a ureteral stone on one side or a small renal stone on one side and a big stone on the side that I'm treating, I can do a PCNL on one side and then put the ureteroscope on the other side. Piece of cake, no problem from that supine position. So the caveat being that sounds like most people in here are prone positioners. If you're used to that prone positioning, there's a bit of a learning curve to get to supine, but it's very achievable. I did it, and I don't think that it's impossible to do. The couple last thoughts I'm going to leave you with are, 1, how do I choose? So either which way, we made this comment a little bit before, only 11% of urologists, maybe as many as 20% looking at the newest data around the world, get drone access. So whichever way you choose, supine or prone, whoever convinces you, me or John Denstead, pick what gets you to the end zone. So hopefully I've convinced you that supine is going to get you there. If you're going to do supine, I think that it's going to be easier to do ultrasound, and I'll convince you why. So I'm showing you this video now.
We have 2 minutes, Doctor.
I've got the needle coming in. Here's the ultrasound probe. Here's the kidney. Needle's in. Beautiful puncture. Urine coming out. Who thinks that's supine? Who thinks that's prone? Who's not sure? Okay. I'll show you a second video. Needle's coming in on top of the probe. Kidney's here. Needle's coming in. And you see it puncture into the collecting system right there. And in a second, you're going to see urine there. Is this supine or prone? Supine? Prone? Who's not sure? I don't even remember. I made these videos myself. I don't even know. If you do ultrasound, they're the same. You use the same techniques, supine or prone, and it's no longer about getting into the posterior calyx for the proper calyx. You just get to the shortest distance. By that, I simply mean that whether you're prone or supine, whatever's towards the top, that's what you hit, and you'll be perfect every time and get to your stones. I'll show you this one last video just to kind of put it all together. So this is a 45-year-old male, right flank pain. You saw the stone here in the right side. One previous stone, previous PCNL. It's a hard-looking stone. So this is a similar video to what I showed before. This is now a supine position PCNL. So here's the hip. Ribs are facing up this way. Here's my kidney. I move my probe back to move the kidney target over here to the edge. And I'm going to stick my needle in right here. and that's the way that you get to a supine PCNL. It's the same as prone, it's just flipped upside down. So in conclusion, there are lots of ways to get to that goal, but hopefully you're going to pick one that's going to get you to do your own access and get you in a position that's comfortable. Supine, there is a learning curve if you're not used to doing that compared to prone, but there are some distinct advantages that you can hopefully work into your practice. And whichever you choose, if you decide you want to change something, stick with it and be consistent. And I appreciate your attention. Thank you.